Maybe
Oh,
you are using.
yeah.
Yeah, now it happened. Please.
Hello, good evening, everyone. So, now in the era of increasing resistance of the antibiotics, we know that all we need is antimicrobial stewardship. But what exactly the antimicrobial stewardship is and how to process the antimicrobial stewardship is what we don't exactly know. And in all the hospitals, there is no antimicrobial stewardship is performing or having the antimicrobial stewardship unit. So today's topic is process measures and a clinical outcomes in antimicrobial stewardship, that is by the Dr. Satyanarayan Reddy, who is working as an antimicrobial stewardship clinical pharmacist at Amrita Hospital and a research center, Faridabad. He has 2 years of experience in infectious diseases pharmacist as well as an antimicrobial stewardship pharmacist. He enthusiastically participated in the projects and worked in a project such as initiating the implementation of antimicrobial stewardship, now working as a clinical pharmacist in a Faridabad. And his areas of interest basically is antimicrobial stewardship in a department of infectious diseases as well as microbiology and PKPD. So without wasting time, let's start to the today's lecture, which is on a topic of process measures and clinical outcomes in antimicrobial stewardship. Over to you, Satya.
Yeah. Very good evening, all. Is my voice audible?
Yes.
Yeah. Thank you for the kindful introduction, Dr. Surabhi. Now, I'll try to share my screen. Let me know whether it is visible or not. Okay. Yeah. Is my screen visible?
Yes, it is visible.
Yeah. Very good evening, one and all. Thank you for joining today's session and followed by myself, Dr. Satyanarayan Reddy, working as a clinical pharmacist in infectious diseases and also taking part of antimicrobial stewardship. So I'm working at Amrita Institute of Medical Science at Faridabad. Uh, Generally, now I don't have any relevant financial relationship with any commercial interests. And first, let us start with the session. Like learning objectives of this session would be what exactly the quality measures is, how does this quality measures and process measures are correlated, and then what does this clinical outcome can be like we can get from this quality measure or measuring this process measures, and what is the role of ID clinical pharmacist in antimicrobial stewardship in international and Indian settings with a literature support. First, let us start like what is a quality measure and how it can impact this antimicrobial stewardship. Quality metrics is nothing but you are trying to understand how efficiently the initiated program or something that have been started in the hospital and how it was running. To measure this, we use these quality measures. So first we need to understand about quantity measure. There will be two parts. One is quantitative research and one would be qualitative research. So in a same way, in a clinical aspect, there would be quantitative measures and also qualitative measures. So these two are like something which runs parallel, but these two are different. These two helps in understanding how well I initiated antimicrobial stewardship is running and how it is monitored, tracked, and documented. So this qualitative measures helps in understanding the exact the present scenario in the institute, and this helps in addressing the gaps and helps in closing the gaps. So this is the way we just use this measures as an steps to build a system and to run the system. And process measures. Process measures is nothing but see, to understand one complete program, we need to measure its outcomes. So for this, we need to design process, few things to measure the process. So for this, we use this process measures as an tool to understand the achievement. I mean, understand the complete system and what and all were achieved. So, for example, process indicators nothing but To understand the compliance of institutional guidelines, we use antibiotic policy as a standard. With that, we'll try to track down the daily cases, and we'll try to understand how many cases are getting compliance to empirical therapy, definitive therapy, and also any surgical prophylaxis cases. We'll try to measure surgical prophylaxis. So in this way, we'll try to use this process measures. And clinical outcomes. What does this clinical outcome measure means? If you are measuring something, if you want to improve something, you need to measure it. In a same way, to measure something, you need to have certain standards of settings. So, as an whenever you start something, surveys, surveillance, if not any day-to-day ward rounds, first we'll understand the ground reality. For example, what is present scenario, and followed by after implementing something called stewardship practices, to which extent it was reached. So in this procedure, this clinical outcome indicator would help in understanding this particular improvement, and helps in knowing the addressing the gaps and knowing the gaps. First and foremost process indicator, it would be like, in generally when you take antimicrobial stewardship, there are many process indicators, but I want to highlight few which are most important and primarily concerned. First, we will be taking care of this particular formulary restriction. So this formulary restriction would help us to understand what drugs were approved by FDA, and which drugs were mentioned in WHO aware antimicrobial list, so that we can maintain or we can track the rational use, and also the promoting rational use of antimicrobials that were approved by FDA. So here the number of it would be like for something, for example, your formulary have 20 to 25 list of antimicrobials. In that you can figure it out how many were FDA approved drugs and how many are non FDA approved drugs. If there are something, you can address this gap and you can close this, so that a rational and promoting this rational usage of antimicrobials helps in using a proper way of antimicrobial. So this is one of the important primary process indicator that starts from pharmacy, hospital formulary. And second, it would be like pre-authorization strategy. Pre-authorization strategy in the sense it includes more towards clinical ward rounds. So here, whenever you are dealing with any reserve antibiotics or high-end antibiotics, generally will be, I mean, clinical pharmacists would be reviewing the prescriptions or auditing the prescriptions. Based upon their audit, they'll be understanding what are all the restricted antibiotic cases that need to be tracked and that need to be monitored. So this would helps in understanding the optimization of restricted antimicrobial usage. And this is one of the primary work role of this work objective of clinical pharmacist in ward rounds. And third one, it would be prospective audit and feedback. This is general one, not only in something antimicrobials, but also this is a common role of clinical pharmacist. Here, generally, it would be will be clinical pharmacists would be auditing the cases, and we'll be understanding what is the dosage regimen, and also the dose frequency, and followed by duration of therapy. All this would be there. So in such a way, it would help in understand the case, and followed by adding a feedback in a form of intervention or observations. This would be discussed with the clinical team, and the decisions will be made accordingly. So, for example, if you take the clinical discussion of empirical therapy and surgical antimicrobial prophylaxis at bedside, so this would be like based upon every institute have some SDGs, nothing but standard treatment guidelines. So, based upon this, this would be there. So, this is one more important process indicator. Here we will be assessing antibiotic prescription patterns, and out of it we will be like adding our interventions or our observations within 48 to 72 hours for an empirical therapy, or even for definitive therapy it is possible. And next, it would help us in understanding the irrational composition of consumption of antimicrobials. And the next one, it's like here we'll be also dealing with, for example, a clinical pharmacist is like reviewing a case or auditing a case and adding their feedback. So here we will be tracking how many cases were reviewed and how many feedbacks were mentioned. So it is like simultaneously we'll be auditing the case, and also we'll be cross checking about number of feedbacks that were reported by a CP department or CP team, within that particular day. So, for example, for example, a CPE is monitoring or tracking 50 prescriptions per day, out of which how many were added feedback in intervention form within the 24 hours. So, this is one of the key process indicator, and this helps in auditing and providing feedback for the prescriptions. This also helps in understanding the tracking the acceptance rate of each and every cases. For example, we can do it ward wise, department wise, even like physician wise, so we can understand the acceptance rate and compliance rate towards our interventions. And one more next is tracking the complaints. Here it is about earlier we talked about this particular feedback, but here it is completely about after giving a feedback, how many were for example, you gave 10 interventions or 10 feedbacks to a doctor or a clinical team, out of which how many were accepted by them and followed by implemented and that were followed. So this indicator helps us to understand tracking the compliances of our interventions, and also we can also track the other things. For example, an institute would be having antimicrobial policy and antibiogram. Based upon this, a local antibiotic policy would be designed. So you can also cross check the compliance rate of STGs. This is the one, and also you can also track empirical therapy drug of choices based upon your antibiotic policy again. So this helps in understanding the adherence of antibiotic policy, and also helps in understanding the compliance rate towards the antibiotic policy. And next one is culture based or definitive therapy tracking. Generally, our therapy would be divided into three, like everyone know: empirical therapy, definitive therapy, and for surgeries it is called surgical prophylactic therapy. So when we are like dealing with culture positive cases, after 48 hours or 72 hours, there would be a AST report generated. After that, you will be having certain report with particular organism in a sample and its AST patterns, nothing but MIC values and all breakpoints of each and every drug. So after this, whether the therapy was adjusted as per the report, and also the dose, the frequency, all these were done or not, this can be tracked using this process indicator, and this is called a best way to understand definitive therapy compliance rate. In this you can understand that is the key point is to track the transition rate of empirical to definitive therapy, whether it is like de-escalated or escalated. So in this way, you can understand these two components, and it would helps us to understand the cases transition towards definitive therapy and de-escalation rate if a patient is getting discharged or if a patient is responding to the therapy. And next one, it's all about understanding the percentage or rate of reduction in antimicrobial consumption. Here we will be tracking aware category list of antimicrobials in hospital formulary. So this one would helps in understanding antimicrobial consumption data. To understand this, we need to do few, I mean, we need to follow few tools. For example, DDD per month, DOT of individual ward per month. So this will helps us to understand whether the usage of an antimicrobials in a particular ward is it going way high or like in a normal limited way, for example based upon the number of patients admitted in the ward. So everything would be understood by this particular tool and particular indicator. So here it is all about you need to have good IT support and also HIS support. I mean electrical medical records, and also the pharmacy support. So based upon all these facilities, only we can say that this particular DOT, DDD, all things can be achieved. So the clear clinical outcome of this is we can measure monthly antibiotic consumption ward wise, department wise. So it would be very better if we prefer DOT than DDD, but it is not like easy one. It's a bit challenging. And out of this, one more is also we need to train, we need to educate our clinical team, both all the, I mean, both clinical and also clinical team in the sense physicians, microbiologists, and all, and also clinical pharmacists and other supporting staff like nurses even housekeeping staff about infection prevention control practices, and all these are all important. So this is one more thing, you can do a pre and post surveillances for this to understand whether their knowledge is improving or not. In our hospital it is a common practice that was done. We'll be doing a pre and also we'll be dealing with the post. So we'll be cross checking a monthly analysis whether their awareness is improved or not after repeated educational sessions. And this is one more way of auditing. This is based upon syndrome bundle audit. So here we'll be having few high risk diseases or clinical indications based upon the institute. If you take this MRSA cases and carbapenem resistant bacteremia or whatever it may be, the patients who are infected with carbapenem resistant enterobacterials, and also sepsis cases. In MRSA, we'll be tracking down a few key important aspects. For example, whether a patient underwent this particular complete duration of therapy and they have been followed this MRSA guidelines or not. I mean, the isolation guidelines that need to be followed. And also, when you are dealing with carbapenem resistant enterobacterials, we'll be dealing with particular MIC and adjusting the dose, and also the duration of therapy, and also the re-emergence of infection. This is also one of the important factor to understand the readmissions or re-emergence of an infection, nothing but relapse of an infection. And in sepsis, to confirm or to understand the severity, we'll be having few indicators. For example, everyone knows like SOFA score, sepsis bundle, that are used to track the severity of an indication and the patient condition. So this helps us in understanding in what way, like whether patient is responding, or like how the patient need to be taken care regarding the input of fluids, and also the important adjustments of dose when a patient is undergoing sepsis induced AKI. All these things need to be monitored. And next, pneumonia. If it is like understanding community acquired pneumonia and also hospital acquired pneumonia. If it is hospital acquired pneumonia, again you need to take care of VAP bundles. So this is one more thing as an indicator in what way we can measure that whether the things were in place or not as per the bundle care. And urinary tract infections, bacteremia. So in the same way, all the particular indications have its own indicators to monitor and taken care of. So this helps us in understanding the compliance rate towards standard treatment guidelines as per the hospital antibiotic policy. Yeah. Next one, it is about surgical antimicrobial prophylaxis. This is also one of the important tool to understand how well this surgical antimicrobial prophylaxis is implemented in an institution. For example, whenever we consider a surgery, here we will be tracking down. For example, again, it would be based upon the site. Is it a clean surgical site, or clean contaminated, or dirty wound? So based upon this, all these particular following list would be dependent. So for clean and clean contaminated wounds, it is all about we need to take care and we need to give good good way of following things. For example, we need to take care of the administration of antimicrobial dose as a prophylaxis need to be within 60 minutes when we cross check with the incision time. So this deals with administration of antibiotic within 60 minutes. It's need to be there, and followed by choice of antibiotic agent. It should be based upon antibiotic policy that was framed based upon the local epidemiology patterns of an bacteria. So it's like it would be from different from place to place. I mean, different from institute to institute exactly. And also the time of administration. Generally, whenever you are dealing with surgeries, it is that on the day of surgery, if a patient is elective surgery and it's like a like planned surgery, the antimicrobial prophylaxis need to be started on the day of surgery, and it should be used less than like 48 hours. I mean, post surgery it should not be like more than 48 hours. If it is going more than 48 hours, it is that it is an extended therapy, and followed by it is a misuse of antibiotics. This would again increase the chances of antimicrobial resistance. So this is one more thing we need to keep in mind, like post surgery how many days the surgery antibiotic days is going. and also redosing. For example, any surgery that happens more than 3 or 3.5 hours, a redosing is must and should, because it is like we need to calculate based upon the half life of a drug, and followed by we need to adjust its redosing. For example, when you are dealing with cefuroxime, it is having an half life of 1 or 2.5 hours. So whatever the drug it is, after completing two half lives, it becomes, or it goes beyond the it goes towards the lower affinity level, which cannot deal with the infection. So that's why we need to give another dose to deal with maintaining of concentration of antibiotic in body or plasma. For example, again, for example, ceftriaxone is the one more thing which has a half life of 6 to 8 hours. Fluoroquinolones also have a half life of 6 to 8 hours. So that for this, there is no need of redosing unless and until the surgery is going way beyond like 6 to 7 hours. And duration is nothing but the same. You need to track down how many days the surgical prophylaxis was given to a patient based upon the indication. You can understand the complete picture if you follow all these things. And also, this is one more thing which I mentioned earlier. Here you'll be in this indicator, you'll be cross checking the readmission rate of a patient uh, in an institute. I'm sorry. And also, it would be very good to understand like these kind of 30 days mortality or readmission rates or Clostridium difficile infection rates. All these are very important because all this like would enhance again the antimicrobial resistance. So here we'll be cross checking, we'll be using a formula. First, it's like number of patients readmitted within 30 days after a discharge, after getting discharged towards this particular, after recovering from a particular infection. And the denominator would be total number of patients discharged from the institute or facility within a specified period of time. And yeah, this is one more bundle and one more indicator that we need to cross check. Here you can understand it is completely about hospital surveillance of hospital acquired infections. So this is generally major part of infection prevention control too. So here we'll be cross-checking catheter associated related infections, central line associated bloodstream infections, surgical site infection, and also ventilator associated pneumonia or ventilator associated infections that are arose after the admission of patient into the hospital setup. So all this would helps us to understand the infection prevention practices that were practiced in the institute. For example, hand hygiene, and also when you are talking about urinary tract catheter, whether the catheter is like maintained below the bladder level towards the bedside or not, and also the hygiene that was mentioned, and also when it is surgical site infection, whether it was maintained very well or not by the nursing staff, and also before and after touching a patient and hand hygiene step was followed or not. So all these things would help us to understand how important the infection prevention control practices are important, and how this would affect the infection rate and emergence of antimicrobial resistance for a particular infection. And also, these are all the importance to enhance the patient safety. First, it is infection prevention control practices. Unless and until this is not achieved, antibiotics won't be so beneficial. So this is the one of the important factor to include. And also to understand the readmission rates, to understand this hospital acquired infection, one is readmission rates and one more is this C. diff rates that are happening in the hospital when a patient is on completely like prolonged therapy of on antibiotics. There are many drugs that can enhance, for example, meropenem, ceftazidime avibactam, and also clindamycin. So many drugs are there like that induce C. diff rates. So it can be calculated by using a formula. It is like number of patients newly diagnosed after admitting into the patient by number of inpatients per specific period of time into 1000. So as this C. diff rates will helps in understanding like in what way this even the drugs called the beneficial drugs called this high end antibiotics, for example broad spectrum, can turn into a kind of poison. So it need to be tracked down and it need to be documented. So that's why even having this as an indicator would help us in understanding how well the hospital infection prevention control practices are going on, and also how well the cases were reviewed and antimicrobial stewardship is going on. So this is one of the important criteria to include this. And one more additionally, we have it is to understand, generally this MDRO incidence rates were done monthly basis. We'll be understanding how many MRSA, how many VRE, I mean vancomycin resistant and enterobacteria, enterococcus, and also carbapenem resistant pseudomonas, carbapenem resistant Klebsiella, carbapenem resistant E. coli. So all these things need to be in picture. Then only we can understand which MDRO is very specific to the local area, and followed by framing the policy and also changing the policy very periodically, yearly once. Generally, it happens yearly once based upon the antibiogram rates. And next thing is 30-day readmission that we have discussed just now, and 30-day mortality rates and percentage of cost of antimicrobials to total drug in the hospital formulary. This is also one of the important indicator that we can track. For example, if your hospital formulary is having like 100 drugs, out of 100, how many are antimicrobials? And out of antimicrobials, how much the hospital avenue, the economy is going or coming because of antimicrobials. So you can even understand the cost of antimicrobials that can impact towards the hospital formulary, so that we can understand in what way they are misused, or they are like whether they are like going accordingly hospital formulary, which is like having this WHO aware classification into picture or not. So this is one more thing. And these are all the few literatures that are there, that were published recently. This is a paper that talks about, it is on 2024, I hope it was published 2022. This 2021 paper was published in 2022. Here this paper talks about exactly, it is an inclusion of 13 review papers and also other papers talking about how this clinical pharmacist interventions, and also how their presence can impact antimicrobial stewardship in hospitals and also in patient safety. And this is the next year, it was published in 2022. So this is also paper who I mean which has a good literature on different antimicrobial interventions by CP, and how it can show an impact on quality and quantity of an AMSP stewardship practices, exactly to say. And this is one more paper, it was done in this is one more paper that was done by US. So here they are talking about how a clinical pharmacist involvement can decrease the antimicrobial consumption, decrease the irrational prescription patterns of antimicrobials, and also decrease the mortality rates by designing a good dosage regimens, dosage adjustments, how it can improve the patient safety. So all these were all mentioned in this paper. And next it is about, it is a particularly in Asian population that you can think like, where India also is involved. This paper is explaining about promoting of optimal usage of antimicrobial usage in the presence of clinical pharmacist, and also involving CP into antimicrobial stewardship helps in promoting optimal antimicrobial use, and also decreasing the antimicrobial consumption, and promoting the promotion rational usage of antimicrobials. And also presence of an clinical pharmacist helps in patient counseling, and also helps in understanding the patterns of this usage, and also educating the clinical educating healthcare professionals. So in this way, it's all about enhancing the awareness of our team, and followed by counseling the patients. So would help in improving the like improving in the sense the misuse of an antimicrobials would be coming down, and how it can enhance the stewardship quality. And this is also one of the paper that was talking about how a CP involvement can enhance the stewardship practices in the hospital. It was done in three countries: India, South Africa, and UK. And also these are all the few main core clinical pharmacist interventions, where a picture of clinical pharmacist comes into picture in stewardship. That is, when cross-checking guidelines-based antimicrobial stewardship, in a mainly this antibiotic policy comes into picture. Like we can understand whether the cases are sticking to policy, mainly empirical therapy, and also pre-authorization strategy, prospective audit and feedback, and also we can understand the culture, the transition of empirical to definitive therapy, the compliance rates, how many feedbacks were considered, and what way this particular transition of definitive therapy is helping in making the patient to improve from infection. And also this understanding tdm levels, tdm literature, and designing the dose accordingly. And also, whenever we are dealing with penicillins, and also the penicillins which are about the same drugs, like for example penicillins have same side chain with that would be with cephalosporins first and second generation. So when you are dealing with this, cross checking with allergies, adverse drug reactions, and also the drug food, and also all these interactions. Also it would be helpful in understanding DDD, DOT, LOT concepts when we are tracking these quantitative measures. And also taking care of formulary management. Like earlier we talked about the list of aware antimicrobials that need to be there to promote rational usage. So this is one more thing. And also tracking down hospital acquired infections, MDRO rates, and even including and training nurses, doctors, other pharmacists, and fellow healthcare professionals to understand how this IPC practices would help in decreasing the MDRO rates, and also understanding the diagnostic stewardship practices, and improving in this particular areas would helps us in uplifting the rational use of antimicrobials and decreasing of resistant rates. So everything is something, in antimicrobial stewardship. It is not like one person. It is a multidisciplinary team need to come into picture. Then only a success of antimicrobial stewardship can be implemented, and the practices can go to a next level. And this is one more topic, like how a clinical pharmacist involvement can help in pharmacoeconomic aspect during the consumption of antimicrobials. So this paper talks about exactly, this the way high usage of antimicrobials would enhance the financial burden on patients. So for this, it is like involvement of pharmacist made this over consumption of antimicrobials and decrease the cost burden on patient. And this is also the same, like how a clinical pharmacist role helped in it was done in UK hospitals. Yes, exactly. So this is one more paper on economic analysis. And in what and all other ways a clinical pharmacist involvement can enhance the stewardship. That is, just now we mentioned in economical, it is about saving the drug cost and cost avoidance, the unnecessary cost. For example, if a patient was admitted with the one particular indication and he got hospital acquired infection, so the cost burden would increase. So again, designing a drug regimen based upon this particular AST reporting would helps in decreasing the hospital stay and decreasing the economical burden on the patient. And also in clinical aspects, it is like improving the quality of prescribing, reduce the number of medication errors, drug related problems, and also therapeutic goal attainment in particular conditions, like when example vancomycin, amikacin, voriconazole, all these drugs were in like in use, like example narrow therapeutic drugs. And also this particular involvement of CP can helps us in understanding the cost consequences analysis, how it impact. Mainly when we are talking about process measures, it is all about quality and quantity, nothing but to know and to understand the improvement in particular stewardship. Something need to be measured. That something is because of this quality, understanding the improvement of quality. For this we require a quantitative measures. So in this way both quantitative and qualitative are like two pillars of understanding the implementation of stewardship in the hospital or in any institute. So this is one of the literature that was published. It is all about qualitative and quantitative methodologies, which could helps us in enhancing the stewardship practices, and followed by in what and all ways it can be examined, tracked, monitored, and documented. And this is a literature that in which from which I gathered all this information. So by this I can conclude the session. I am happy to hear if there are any queries. I'm happy to answer. So yeah, I hope it's clear.
Thank you so much, Satya. Very nice talk it was. Actually, I have one to two questions to ask to you.
Yeah, yeah,
So,
please.
yeah, number one is, did you have different antibiograms? Like you have antibiogram site-wise, body site-wise infections, or what exactly your hospital antibiogram is like?
Okay. See, antibiogram, it has many ways, but as a beginner, if you are starting as a beginner, it is like simply we can start as per the bacteria wise and sample wise. But in our hospital, if I can ask, if I can exactly answer to your question, in our hospital we are dealing sample wise, but also we are involving department wise, because it need to be, for example, in general economy, in general normal wards, unless and until less when this critical patients come into picture, this dosages, drug of choice, all will change when compared with the normal patients who are admitted in normal ward, when we compare with the patients admitted in the critical care units. So we are following here, like units wise, units in the sense department wise, like based upon the critical area, sample, and organism.
Okay. And number two is what parameters you are following, like DDD or total duration of antibiotics in days for the consumption rate, and which one is more accurate and which one is easy to follow. So, what's your take on that?
Understood, understood. Clear. It's a good question. When we are dealing or when you are talking about metrics part of stewardship, uh, see, for us to calculate, if it is like you want to talk about the easy one, then it would be the DDD. But the precise one would be DOT.
Yeah,
But
right.
DOT is very challenging one to deal because you need to have good support in the sense both in aspect of IT, both in aspect of your team, manpower. So this
Yes.
need to be there. It should not be like missed. For example, one or the other day, one member may not be available on this ward rounds. So when we can't capture this particular data clearly, it is tough to give a good picture. That's why we can start with easy, and then when a complete team was built and followed by we have, if we can reach to such a stage like we have every facility, then we can think about DOT, LOT even.
Okay,
But
thanks.
DOT would be the precise. Easy one is to start with DDD.
Okay, okay. And I also, sorry, I was also asking about what parameters you are included in finalizing the adherence of your surgical prophylaxis. Like you have
Oh,
mentioned two, three parameters. So for the adherence, like adherence rate of your to your surgical prophylaxis within your hospital, what parameters you are going to take?
yeah. Okay. First and foremost, we first talk with drug of choice. For this drug of choice, we depend upon or we rely on antibiogram, because this local susceptible patterns of this bacteria would change from place to place or institute to institute. So we design our surgical prophylaxis policy based upon the antibiogram, first and foremost.
Okay.
And second thing is, even we track the number of sorry, before that we will track whether the antibiotic was administered within 60 minutes
True.
of when we compare with the time of incision. And
Okay.
third one, what is the duration of antibiotic that was going to a patient post surgery?
Yeah.
This is
That,
also one more thing we keep
yeah,
in
that
mind.
you have said less than 48 hours.
Yeah, but we can't ask when we compare with the reality. It's
Yeah.
not like easy to deal with the surgeons.
True.
So it's like first we need to give them a privilege that what exact way they were comfortable with. Is it like something, if they are take it as an example with the 7 days. If earlier they were giving to us 7 days, we can request them, could you please decrease it to 2 more days, and can you make it for 5 days? So
Okay.
slowly, it's like something we need to build a step by step. All of a sudden, 48 hours or within 24 hours, it is not achievable
It's like a
because
slow
stewardship is
poisoning.
nothing. Sorry.
It's like a slow poisoning.
Yeah. Because stewardship is something about behavioral therapy. First, it need to be a patient person need to trust us. Then only all things would come into picture, and also management support. So yeah, it need to be started as in baby steps, and when we achieve it to the extent, even 0.5% improvement is a good achievement when we compare.
Okay.
It's not like
And you
something
said
it is.
that in a redosing, you consider more than 3 hour surgery or 3.5 hour surgery, then you redose the antibiotic, right? According
Yes,
to the
exactly.
behalf of the antibiotic. But did you consider the blood loss?
Yeah, definitely. If it
Yeah.
is something going way beyond like 900 ml or like 1.5 liter,
It does. Yeah.
definitely it is a point that we need to think, we need to be more precise. I mean, we need to be cautious. For example, if you are giving, take an cefuroxime, which is a common surgical antimicrobial prophylaxis agent that is used in our hospital. When it
Yeah.
is about calculating with blood loss, if you are giving within 3 hours or 3.5 hours, when it is something a patient having heavy blood loss, you need to give it like at the end of third hour, should not wait till 3.5 hours. So in such a way, we need to be like cautious. We need
Yeah.
to give it bit early.
Yeah. So my last question is, what your
Yeah.
take on pharmacoeconomics while in antibiotics and in antifungal drugs also? Like your take or how you incorporate in your daily practice.
Okay. Pharmacoeconomics is also one of the part that comes into picture, but this is a low hanging fruit. If you ask, I can say this won't be much highlighted, but it has a great impact. Um, for example, it deals with the, I'll take it as a surgical prophylaxis as an example. If it is something you are giving a patient a 3 days of post surgical 3 days of antibiotic therapy after surgery, this reflects if a patient takes till seventh day, it increases the length of stay in the hospital. It increases the financial burden regarding medications. It increases the economical burden on even the patient. So it's all about, even we need to cross check with economic aspect.
Yeah.
So it is a most important aspect that need to be there. So then we can understand, it's not like something we should not showcase to the our management people, because management would always look towards having a good avenue also if you talk about. So it is like something, if we can provide a proper antibiotic therapy, we can decrease antimicrobial resistance. So in such a way, we need to showcase our data so that they also can be satisfied. It's like making them to understand practically it is true. Should
Yes.
not more focus on financial thing.
Yes. Yes.
I hope
Thank
I
you so
answered your
much.
question.
Yeah. Truly. So yes, thank you so much, Satta. It was a really wonderful and informative session. Hope you are doing well.
Yeah. Thank you so much for the opportunity again to FCPI.
Yeah. Thank you so much for
Yeah.
having us as well. So let's finish the talk now. Thank you so much.
Okay. Thank you. Bye bye all.
Yeah. Bye bye.